Hello, and thank you for joining us tonight for our free webinar, Integrating Classical and Modern Acupuncture Orthopedics, the Cervical Spine, featuring Dr. Anthony van der Muhll. My name is Jeff Bloom, Education Marketing Manager here at LASA OMS. For over 40 years, LASA OMS has been striving to promote the growth of the acupuncture industry by providing quality products, great prices, and the best customer service, as well as supporting the many schools and continuing education efforts available. With our free webinar series, we intend to provide free educational opportunities taught by some of our industry's most renowned practitioners and educators. I would like to take a moment to acclimate you to the webinar room. To the right of the video screen, you will see 3 tabs: Chat, Questions, and Polls. To chat with other attendees or to communicate any technical difficulties, please use the Chat tab. For questions of our guest speaker, please make sure to use the Questions tab, and we will get to those at the end of the lecture. Please note that each webinar is recorded, and immediately following the conclusion, you will all receive an email with a link to view the video on demand and a copy of the slides. You may always visit our blog and use the free webinar tag to find all of our previously recorded events. From neuroscience to sports acupuncture to Chinese herbs, you'll find something interesting for every practitioner on the LASA OMS blog. Now for our featured speaker. Anthony van der Muhll is the founder of AOM Professional and has taught certification in acupuncture orthopedics since 2015 and served as clinical supervisor at the master's and doctorate level for over 15 years. He has also taught acupuncture orthopedics and pain management in the DAOM and DACM programs of the Academy of Chinese Culture and Health Sciences, the American College of TCM, Five Branches University, and the Virginia University of Integrative Medicine. He has been a featured instructor in acupuncture orthopedics at conferences of Sports Acupuncture Alliance, the California State Oriental Medical Association, the California Acupuncture and Traditional Chinese Medicine Associates, and the American Society of Virginia, the Acupuncture Society of Virginia. Please join me in welcoming Anthony.
Welcome, everyone. Hi, it's great to be here, and thank you so much, Jeffrey, for sponsoring this event, and LASA OMS for sponsoring this event. And LASA has been my main acupuncture needle and clinic supplier practically since I started my practice in 2003, and it's really great to have this opportunity to give back to LASA and to all of you who I'm sure make use of their excellent range of clinic supplies and acupuncture needles and so on. The topic for this evening is going to be integrating classical and modern acupuncture orthopedics in the cervical spine. We'll start by discussing history and physical exam and get on to assessment and treatment. And Jeff gave a very thorough resume of my experience that brought me to this, and you can read the rest of that slide on your own for the details. But what I want to emphasize is that this is, in some ways, I feel like I've come full circle in my own practice and in my teaching, from starting with a very, I started out really interested in 5 elements and studied with a Taoist priest, and then went through a phase of like pure Western orthopedics, and then starting in 2017, I started both teaching in and taking the doctorate program at the Academy of Chinese Culture and Health Sciences in Oakland, which has a big emphasis on classical Chinese medicine, and which brought me back around to kind of seeing how much overlap there is and how much we can learn from both modern orthopedics and the deep classics, going all the way back to the Neijing and the description of the jing-jin, which are often translated as sinew meridians or muscular tendinous meridians. I personally like to translate them as myofascial tracts. I think that's a much better description of what they are. But the 6 jing-jin, or the taiyang, xiaoyang, yangming, xiaoyin, jueyin, taiyin, that was presented to me in the master's program primarily in the context of cold damage and external pathogens and herbal medicine, without acknowledging that that's also how the Neijing describes the organization of muscular skeletal tissues. And it was much later that I learned that and found that it's tremendously valuable to integrate these 2 approaches. So that's what I'm going to try to communicate in as much as I can in a short hour here. So I want to start with just a little cursory review of some of the essentials of Western anatomy, make sure that you can all understand the terminology I'm using when I'm talking about orthopedics here. The spine at every level, cervical, thoracic, and lumbar, it consists of essentially the same critical structures. Facet joints, these are small synovial joints with little tiny discs inside them that can become dysfunctional, not move properly. They can become sprained in acute traumatic injuries. They can sublux out of place. They can become what's called deranged, where the tissues start to get damaged and are no longer have the same integrity. And eventually they degenerate. And the term for that is spinal osteoarthrosis, or spondylosis for short. That's where the purple arrow is pointing to a facet joint in the side of the spine. They control motion in the spine. The discs that function as shock absorbers are full of a very acidic gel, the nucleus pulposus, and if that gets injured or traumatized, it can leak and chemically irritate adjacent structures, which causes really severe burning pain, or it can actually bulge or herniate out through the very tough fibrocartilage ring that surrounds the nucleus. And when it bulges, you can see how close it is to nerve roots, these little yellow structures sticking out to the side. And a bulging disc or an irritated disc can either chemically inflame a nerve root or crush a nerve root, and that causes motor and sensory dysfunctions. So both of these structures, discs and facet joints, have a lot of pain fibers, and when they compress nerves, that causes a lot of pain. But pain is actually not my primary concern when I'm treating a patient who has neck or any spine pain. It's what's happening with the nerve root. And that's because nerves, when they're damaged past a certain point, will not recover their motor and sensory function. And so somebody can be left with permanent loss of strength, loss of sensory function in the limb. So a lot of what I want to begin with actually is about recognizing that scenario, because it was not adequately taught to me at the master's level. And it's something we really need to be on the alert for. Now, in my practice, neck pain has been probably number one or number two, number three, with rotator cuff problems and low back pain being, those are the big three. So this is an extremely common scenario, and so we really need to be able to identify those patients that have more than just pain in their neck, they also have nerve damage in their arm, okay? But taking outside the column, the bony column of the spine, we have lots of muscles whose job it is to maintain our spine in neutral upright position through balanced tension between them, and that also coordinate together to produce motion and to control motion. And when things get out of balance, it's like a rope on one side of the tent pole is too tight, and it pulls the tent pole out of center and creates problems and makes the pole more vulnerable to damage. Okay. So some of the basic questions that I want to ask of any patient who has, and these are, both history and physical exam, these are the diagnostic questions we really need to get to. Is it acute or is it chronic? Was there an abrupt trauma, or did it come on gradually? Is it unilateral? Is it bilateral but asymmetrical, or is it bilateral and symmetrical? I'll explain why. I will explain why all of these are significant. Here's the big red flag, though, and you'll see as we go through these slides, I've got some color coding for you. Anytime you see something red, this means this is potentially an urgent scenario that may warrant prompt referral to a physician for further evaluation. Not because we can't treat it. We actually can treat these things very effectively, but sometimes there's more treatment than we can offer that's needed to really address these conditions. So when there's nerve involvement, such as spinal cord injury or cervical nerve root damage, this is something we really need to monitor carefully and should probably refer to a physician for further evaluation as soon as we see it. Brachial plexus, on the other hand, is not a nerve condition, even though it involves nerve tissue, and I'll explain why as we go. Also, the age of the patient and the stage of the injury. When we're younger or in the early stages of an injury, we're more likely to see simply muscle imbalances, what I refer to as the ropes on either side of the tent pole not being evenly balanced, and that causes dysfunction, malfunctioning motion in the spine. A middle-aged patient or a mid-stage injury is more likely to show derangement, where facet joints and disc structures are actually starting to tear or have holes or weak spots or be damaged in various ways. And then in the older patient or the late stage, it degenerates into osteoarthrosis. The other thing that can happen at any age or any stage is a fracture, but these can be either traumatic injuries or the spine can actually fracture degeneratively. That's really pretty much the only place in the body where we see bone starting to break down simply through age and wear and tear, and that's particularly common in people who have low bone density. Another question I need to determine is this a regional problem where there's also headaches, TM joint is involved, the shoulder girdle, the thoracic spine? I'm not going to cover those other body regions in an hour webinar, but that's an important diagnostic question to keep an eye out for. And then finally, what's the role of psychosocial stress in this patient's symptoms? The neck is probably no surprise to any of you. You've experienced this yourselves in your own body and certainly seen in your patients. It's our canary in the coal mine. It's our bellwether. It's the first thing that gets tight when we're under stress and that starts to dysfunction when we're under stress. So psychosocial stress plays a big role often in significant neck pain. So some of you may be familiar with the mnemonic for orthopedic complaints, LMNOP-QRST. What this stands for, L is location. Is it bilateral, and is it symmetrical or unilateral? And an important technique with the neck in particular is to ask the patient to point to where it hurts. If they point to the slope of their upper trapezius rather than to their cervical spine, even though the patient says it's my neck, it may very well involve their neck, but we also need to assess their shoulder girdle. That's outside the scope of this class, but it's important to consider that this may actually be a problem in the rotator cuff or the shoulder joint or the acromioclavicular joint that's causing a lot of the problems. Medications, I want to know about because the usage of pain medications can be an indicator of severity. And then a couple of critical negatives that I want to ask about. Do you have headaches? Headaches are very often benign. However, there are various serious types of headaches, things caused by tumors, bleeds, strokes, temporal arteritis, etc. Even severe migraines can be very disabling, of course. So when a patient says they have a headache, I need to do a cranial nerve exam. Again, outside the scope, I'm just flagging things that we should not skip over when we're evaluating a patient who has headaches. Neck pain. We want to know if they have headaches, and if so, we need to examine their cranial nerves too. Here's the one we're going to spend more time on. If they have arm or leg pain or numbness or tingling, we need to evaluate their spinal cord function and their spinal nerve roots. And then traumatic injury, of course, in the cervical spine generally is something that is first going to be seen at urgent care or in the emergency room. But if a patient were to come in and say, I had a traumatic injury, like a motor vehicle accident or a slip and fall where I hit my head or banged my neck, I would want to refer them for further care and evaluation right away. Because there's a lot of things that can go wrong with a traumatic neck injury. Okay, so continuing with our mnemonic, palliative and provocative is a common question that we want to ask about. What makes it better? What makes it feel worse? But it's really only diagnostic if the patient gives us very specific answers. So if they just say it hurts worse when I use it or it hurts worse when I'm at the computer, that doesn't tell me very much. But here's what I want to ask. Does it hurt to look down towards your toes? That suggests a problem with the disc. Does it hurt to look up towards the ceiling? More likely to be a problem with the facet joints and the central spine. The central canal of the spine can narrow in older patients or even in people with congenital anomalies and cause pain when they look up at the ceiling. How about turning to the left or turning to the right? Well, here we have to know, is it same-sided pain? If I turn my neck to the left and it hurts on that side, it's probably the facet joints and maybe the central canal of the spine. But if it hurts on the opposite side to where I'm turning my neck, that's probably muscles like the upper trapezius or the levator scapula muscle. When I turn to the left side, it actually puts the muscles on my left side on slack. So if somebody says, I'm turning to the left and it hurts on the left, I'm pretty sure it's not the muscles that are involved, okay? Another very useful question to ask of patients with any significant neck pain is, does it hurt to swallow, to cough, or to strain, to defecate, or maybe even to laugh very hard? Those all suggest a disc injury as well. When we swallow, cough, laugh, or strain hard to defecate, it increases the pressure on the disc, and that's a very specific and very sensitive indicator of disc problems. The other questions, if we've done our homework and asked the first questions correctly, these other questions don't really add a whole lot to our diagnosis, so I'm going to skip over them. And I often skip them and don't ask them because I've already gotten the answers I want. But if the patient says at any point in response to my questions that they have numbness, tingling, or weakness in their arm, there are two reasons not to wait to refer them to physician. Okay, it's a clumsy mnemonic, but I want you to remember that. NTW, not to wait, okay? First of all, there's all kinds of fairly serious things that could compress or irritate the nerves. The worst case scenario is it's something like an intracranial lesion or disease. Things like strokes or tumors in the brain, okay? Or other systemic neurologic diseases, things like multiple sclerosis. And Another thing not so serious is disc herniations, as we mentioned, or neuroforaminal stenosis. That's meaning it's closing down to the neuroforamen. But if it's a central canal that is stenosing, that is narrowing in its diameter, that can be a problem because that can compress the spinal cord itself. Okay. Now I've yellow coded that or orange coded it rather than red coding because red is really like, you need to see a physician right away. I can treat it, but you also need to see a physician. Yellow is more like this potentially needs referral to a physician. I can keep treating it and I just want to monitor. And if it's not getting better or getting worse, then a physician referral is indicated. Okay. Now, another obvious red flag is fractures, abrupt trauma, severe pain, cervical instability, or osteoporosis, a little bit more of an orange flag here. Malignancy, well, it's very serious, but if they're not seen at the ER that day, it's not a big deal, but they need to be working with their family physician or an oncologist, obviously. And we will pick this up by a slow but progressive onset that just keeps getting worse no matter what, and maybe something like a personal or family history of cancer or systemic signs of cancer or elevated risk factors for cancer. Infections, very rare but very serious in the cervical spine. I once had a patient, this was actually in his thoracic spine, had an infection that ate through a disc and started eating into the spinal cord, and he was paralyzed from that level down. Okay, so that's something, if somebody's showing systemic signs of an infection, then they have neck pain. Another example might be acute meningitis, spinal meningitis. Usually they're going to have something like a fever, they're going to have generalized malaise and so on. But here's my point. When they have arm numbness, tingling, or weakness, it could be any of these really serious things. It could also be something not so serious, but arm numbness, tingling, and weakness is something that we, not to wait, consider a physician referral right away. The other reason I already mentioned, the big number 2 reason, is that there's a risk of permanent disability because nerve tissue recovers slowly and poorly, if at all. Once it's damaged past a certain point, it really won't recover. It'll flatline at about 6 months to 1 year, and then they're just left with permanent disability. Okay. Now, the blue link here, this is a ghost. You're going to have a PDF, so it's not actually going to go to a differential diagnosis table. But in the full length classes that I teach, we go into much more depth on the differential diagnosis here. But we're going to need to move on here. I'm just going to give you some simple thoughts here. With an accompanying headache, we do need to really consider that it may be coming from the brain. The arm numbness and tingling might be coming from multiple sclerosis, from a tumor, from a stroke, etc. If it's bilaterally symmetrical, arm or leg numbness, tingling, or weakness, this also can be coming from the brain, but it might also be coming from the spinal cord or something benign like the brachial plexus. If it's unilateral or asymmetrical, again, it can be coming from the brain, but it may also be a spinal nerve root. Those little yellow nerve roots that we saw sticking out from the side of the spine, or the plexus, which is relatively benign, or it might be a peripheral nerve, something like carpal tunnel syndrome. So these are all possibilities that need to be considered and worked through in our differential diagnosis. Okay. What I'm calling here a shawl shape, like kind of something draped over the back of somebody's head and neck and their shoulders and their upper arms, that's very characteristic of the spinal cord being compressed in the cervical spine. This is usually caused by central canal stenosis, a narrowing of the diameter of the central canal that's starting to compress and irritate the spinal cord. And in an older patient, that's much more common. We'll see somebody holding their neck in a kind of forward flex position, chin towards chest, and they don't want to look up and back because it hurts. This can also, however, be caused by a fracture. Traumatic one, typically those are going to be seen at the ER. If they show up in your clinic, that's really 911 time because they could paralyze themselves from the neck on down if they move their neck the wrong way. But it can also occur degeneratively in a patient who has osteoporosis. The cervical vertebrae can start to kind of crush and collapse just from the weight of the head. It's more common in the lumbar and thoracic spine, but can also occur in the cervical spine. And as I mentioned, tumor or infection, if they start to eat into the spinal cord, we'll see this shawl shape. So what I want you to remember is this bilaterally symmetrical shawl draped over from the head down to the upper arm is not a good sign. It can be benign, but it's often fairly serious. Okay, and the more distal the symptoms, the more severe the situation is. However, if it's a dermatomal pattern, And here's one of many available charts. They're easy to find on the web. They're somewhat variable. There's controversy about exactly where the dermatomes lie. They look kind of like acupuncture meridians. If it's a line running down the arm to the fingers or down the leg to the toes, this is more likely to be a dermatome. Now, a cervical dermatome, a nerve root that's been compressed in the cervical spine, is not going to show up in the legs. It's going to show up in the arms. But these are typically unilateral on the dorsal side of the arm rather than the palmar. And if they're provoked by forward bending, chin towards chest, it's more likely disc. If they're provoked by backward bending, more likely we're dealing with a bony overgrowth that's narrowing the diameter of the neuroforamen. We'll look at a couple pictures of these in a moment. Occasionally, these will show up as bilateral and asymmetric, even more rare bilateral and symmetrical. And the more severe they are, the more constant the sensations are, the more they're felt along the entire pathway. But here's the thing, here's how you recognize this, is the milder ones are felt only in the fingers, at the distal terminus of the nerve root, and kind of come and go. If it's more moderate, they'll be felt more proximally, and if they're more severe, along the entire pathway of the dermatome. Okay? If the numbness and tingling is more in the shape of a glove, involving the entire arm, the dorsal and palmar aspects, the radial and ulnar aspects, this is actually relatively benign, although the patient may be uncomfortable with it. But it's simply a soft tissue compression most of the time of the brachial plexus, which is the bundle of all the nerve roots that exits the cervical spine, passes through these muscles or underneath these muscles, the scalenes, subclavicular musculature, and the pectoralis minor. Sometimes if somebody has an anatomic variation where they actually have a first cervical rib, and that's more of a problem. But usually it's soft tissue, and usually this can be simply corrected by good upright posture, keeping the chin tucked in, the head upright, shoulder blades down and back, your good Tai Chi or Qigong posture. Okay? But stress and shallow breathing and the forward head posture associated with computers can also cause this relatively benign condition that's relatively easily correctable. Okay? So in terms of our physical exam, we want to do a little inspection and observation, range of motion, how far can the patient move their neck through the various planes of motion, and then we've got some neurologic special tests that we'll go through. Okay? So in terms of inspection and palpation, here's where we can start integrating some of our classical jing-jin anatomy. What I want to point out, first of all, is a horizontal crease in the back of the neck typically occurs at a level where the spine is beginning to degenerate. Think of taking a paperclip and bending it back and forth. There'll be an area where it starts to heat up and starts to fail and weaken at that point, and there'll be a little line that develops and eventually would snap. Same thing happens in the cervical spine, most commonly at around C5, C6 level, but you can see it right on the skin, typically in older patients or long-standing hypermobility at a certain level of the spine. The skin will be creased. The collagen fibers are wearing out at that level. And that signals a Tai-yang problem with flexion and extension. If they've got gritty, tender nodules sort of along the side of the head, the lower side of the head, that's more characteristic of Xiaoyang problems. And if it's in the front of the neck along the sternocleidomastoid muscle or the anterior cervical lymphatics are kind of tender and swollen, that's more of a Yang Ming presentation. Okay. Now, we want to ask ourselves what tissues are limiting somebody's range of motion. Starting in the upper left, if their forward bending is limited by pain, this is a disc, more likely a disc, and it's a Tai-yang jing-jin injury. If it's more limited going backwards, we have to ask, where's the limitation taking place? Where does it hurt? Very rarely it's in the front. That would be like a severe whiplash injury that tears up the scalenes and the sternocleidomastoid muscles. This is the Yang Ming presentation where muscle pain in the front of the neck limits their extension backwards. But much more commonly, it's bony overgrowth, facet joints and/or central canal or neuroforaminal stenosis that limit backward bending, also a Tai-yang presentation. If the problem is rotational or side bending, these are Xiaoyang motions that are being limited by pain. And as I mentioned earlier, if it's the same side, we're dealing with bone and joint, but if the pain is on the opposite side of the limitation, it's more muscular, okay? And that's true with both rotation and the side bending, okay? Now, here is an image that will help us understand, I think, why a herniated disc um, can irritate a nerve root. Okay, so the arrows here on the lower image here, the up and down arrows, this is what happens to a disc when we bend our neck forward, is it compresses the disc in the front. Think of this like an ice cream sandwich. If you squeeze the front of the ice cream sandwich, where's the ice cream going to go? It's going to push out the back in the opposite direction. And when it goes out the back, where the smaller arrow is pointing posteriorly, it will run into a nerve root, and that causes pain. So the first stage is pain, and you've got these stages here on the left here. Pain, which is actually the least serious presentation. This is why this is so important to understand, because understandably, ourselves and our patients will think pain is the most serious. But pain is actually the first stage. What comes next, think of this like a phone line that's being slowly damaged. At first, there's pain, but then there's kind of tingling and paresthesias, crackling on the line, static, because the pain signal is not getting through as clearly anymore. Odd sensations. Then we start to lose sensation altogether, numbness and sensory loss. The phone line is starting to die off and going dead. We don't hear that much anymore at all. Then we get fasciculations and cramping. So this is really the point where things become much more serious. We get abnormal motor activity because the motor core of the nerve is being compressed. Then we have painless weakness. It's actually more severe than pain, okay? The muscles are starting to lose motor function and strength. Eventually they atrophy, and the final stage is total loss of motor function and flaccid paralysis, okay? We don't want to get anywhere near that, of course, as patients or practitioners, okay? So terms you might hear, radiculitis means inflammation. That's really only the first stage of pain. Everything else is radiculopathy. There's some structural damage to the nerve that's interfering with sensory and motor function. So a very specific physical exam maneuver that we can use is we can ask the patient to fake a cough. As I mentioned earlier, now I know it's a little tricky in the COVID era. As long as they got a mask on, preferably an N95, we can still ask them to fake a cough. We should be wearing our N95 as well. And if coughing really makes it hurt in the back of their neck, particularly if it sends pain radiating down their arm, this is very specific for a disc injury, okay? A common scenario is that patients may report this after lying in bed for a while and they've been coughing due to COVID or a flu or a cold or whatever, and then their neck starts to hurt, okay? And they may seek to avoid this by bending their head backwards, okay? Now, joints refer pain as well as nerves, but they don't refer them in dermatomal pattern. It's not like a line that looks like a meridian going down the arm. It is more regional areas. And compared to either muscles or to nerve pain, joint pain is less hot, less burning, and severe, felt as kind of like a deep, dull, empty ache in the bones, not electrical, numb, tingly, crampy, spasmodic, or shock-like. And bones typically don't respond to psychoemotional stress the way muscles do, okay? But all of these things can be present at once. And so that's something that we have to consider as we may be dealing with disc and bony facet joint problems and muscle problems and nerve problems, okay? We just want to know which and to what degree, okay? So here is an image that I hope helps you understand how the narrowing of the neuroforamen, this little hole in the side where the nerve root exits, when the bones hypertrophy due to injury or wear and tear or old age, there's less diameter available here. A young person can bend their head backwards, no problem. But if these bones have grown, the diameter has narrowed, and the spinal nerve root is much more sensitive, is much more vulnerable to being impinged upon, which does not happen with a disc protrusion. Okay, so when we have numbness, tingling, or pain in a limb, some of the physical exam we need to do is we need to assess the strength of the limbs, and that's a crucial physical exam skill, which I can't teach in a 1-hour webinar like this, but is really worth learning. And here are the motions that are myotomes are groups of muscles that are supplied typically pretty much by the same nerve root that work together to perform a specific function, a specific movement within a specific plane of motion. So the nerves that exit at the C5 level supply the muscles that abduct the shoulder. So this is in the upper left of this slide here. Abduction of the shoulder, raising the arm out to the side, is performed by the C5 myotome, which supplies the deltoids and some of the rotator cuff muscles with their strength to abduct the arm. Okay, I won't go through the other ones in this class, but you can. They're very easy to find on YouTube. The motions of the myotome, and medical students have tons of these videos. I think they make them for classes and stuff, and some of them are kind of fun. There's the myotome poem, there's the myotome dance, etc. They're good ways to remember these things. But what we need to know how to do as a practitioner is assess the strength through manual strength testing of the myotomes. And if we find smooth, painless weakness, smooth meaning it's as weak when you start testing the muscle as it is at the end, then we've got a myotomal weakness, and that's a worrisome sign. Oddly enough, if it's a pain-inhibited weakness, if the muscle just won't work because it hurts too much, that's less worrisome, should be less worrisome to us. And the reason, again, that I put so much emphasis on this is because what do patients think is the most important thing? Pain, right? So if the patient's pain is dying off and they think they're getting better and we think they're getting better and we discharge them from care, we may be doing the wrong thing because the pain may be diminishing because the nerve is dying, not because they're getting better, right? So we have to think outside of the pain box. Okay, we're so trained in acupuncture to think only about pain, and we miss really important stuff if we limit our thought process to pain. So let's think outside the pain box about the strength, okay? I also mentioned sensory function earlier, and luckily for us acupuncturists, even without any additional training, there's a very simple way to assess sensory function. When you grab your cotton ball and you get your rubbing alcohol and you swab the places where you're going to needle, the patient should feel cool and wet. We should all feel cool and wet, right? But if the sensory function is being damaged, it's not going to feel cool. It might actually feel warm or neutral temperature-wise, and we won't feel the touch of the cotton ball. And that's because light touch and temperature sensation are the first to go. Okay? So it's a very sensitive test for picking up the early stage of nerve damage. You just simply ask your patient when you're swabbing, like small intestine 3 or triple warmer 3 or Ling or Dabai or whatever, Luojan, your favorite distal acupuncture points on the hand, does it feel cool and wet? And if they say no, or, and compare sides, left and right, the symptomatic side, they're saying, no, I don't feel the cotton ball and it feels warm, you've got some sensory loss going on, okay? So that's our history and physical exam. Now we're going to move on to diagnosis, patterns, and treatment. So I've got some tables here, which I don't think we're going to get through all of these. These are for your reference. You can look at them later, but I want to explain so you have an idea here of what these tables tell you. Okay, so the left-hand column, we see an orthopedic structural or tissue-based diagnosis. Facet joints and facet arthropathy, damage to the facet joints, or central canal stenosis. What is the movement provocation or limitation? It's going to be extension and rotation. They're going to be pain limited. We might describe this in functional terms, not just structural terms, but functional terms. It's a problem of stasis. Things are stuck. They're not moving smoothly. And the TCM correlate, I'm not going to say an exact equivalent, but the correlate is Qi and blood stasis and B syndromes, painful obstruction syndromes. A disc, on the other hand, is going to limit flexion, and it's more of a dysfunction of stability and loading. The spine is a little unstable now, and when it's loaded, it hurts. This is more of a deficiency in heat presentation, okay? If we don't have either of those present, we're dealing with just muscles on the surface, a much less serious presentation. There may be no limitation at all in the motion, or it may be variable. One day it's sore one way, and the next day it's not. This is more of a problem with transitions and loading. And here we've got deficiency, but also a lot of stagnation and heat in the muscles, okay? A spondylolisthesis is a fracture. As I mentioned, it's going to hurt worse on extension. And now again, we have a stability dysfunction, a loss of stability, that there isn't really a good way to describe this in TCM, but deficiency in heat is probably as close as we can come. And then here's the other very common presentation of the neck, is there's really no structural pathology at all, no tissue diagnosis at all, and there may be no limitation in motion either, or any motion may be a little bit limited, and the dysfunction is sensitization. The muscles are sensitized, the pain threshold is lowered because of psychosocial stress, anxiety disorders, and in TCM terms, you might see Shen disorders or Zong Fu or five-element disharmonies. Okay, so here are some common clusters of regional problems, and the one we just talked about is relatively minor myofascial pain or minor dysfunction in the cervical spine that is being significantly amplified by psychosocial stress. Because again, the neck is a bellwether region. Okay, so that's one common presentation. Another, when we see this numbness, tingling, and weakness in a limb, or pain radiating down a limb, is a multiple crush syndrome. This is where there's damage to the cervical nerve roots, but also to the brachial plexus and also to the peripheral nerves. So maybe something like carpal tunnel syndrome, brachial plexopathy, and a cervical nerve root. And that's because once a nerve is irritated or injured at one point along its pathway, the entire pathway gets sensitized, and relatively minor problems become much more symptomatic. So here we're dealing with qi and blood stagnation, deficiency, and heat. Another common cluster is a dysfunction of the cervical spine plus rotator cuff problems. So when the rotator cuff is injured, or the shoulder joint, which is my next one here, but we're going to talk about the rotator cuff for the moment. The rotator cuff is injured and weak. What compensates? The upper trapezius muscle. The upper trapezius attaches both to the clavicle and to the scapula and are very involved in shoulder motions, and also attaches to the cervical spine. So when the rotator cuff is weak, the upper trapezius takes over and tries to elevate the arm and control motions of the arm, but it's not really designed to do that, and it develops trigger points and gets tight and tense and sore. So here we're dealing with a B syndrome because there's a loss of range of motion in the shoulder, and in the neck, qi and blood stagnation, deficiency, and heat. Okay. What about the shoulder joint itself, or the acromioclavicular, or even the sternoclavicular joints? These are the three bony joints that make up the shoulder girdle. And if any of those are sprained or torn, or maybe an old injury, an old dislocation, and they're now lax and unstable, that too causes the upper trapezius to overwork, and then we've got cervical spine plus a shoulder problem. So all of these can be present simultaneously. In fact, that's pretty common to see all of them together in a patient with any really significant or long-standing or severe neck pain. Okay. So what are our treatment goals? So if the physical exam is pretty normal or close to normal, really it's about reducing psychosocial stress. You can rely perhaps entirely on distant needling and, five-element, Richard Tan, Master Dong, 8 extras, TCM, Japanese, pick your, ear acupuncture, etc. Distant acupuncture works great for reducing psychosocial stress, and I use it all the time with my neck patients. Even if they do have structural problems, I also treat their psychosocial symptomology. Okay, so what we need to do is reduce stress, and that helps muscles to relax and restore blood flow to the area, and then the pain goes down. Okay. But if we have some physical exam findings like dysfunctional or painful or reduced range of motion, we need, our treatment goal is we need to get them back to full pain-free range of motion in all planes. And this is a subtler point that we won't go into in detail in this class in this 1 hour, but normalizing their joint tracking, how the spine moves, is also important. If we have radiating limb pain, numbness or tingling or weakness, then we have to work on resolving that, the limb symptoms, including fasciculations or cramping in the limb, pain and paresthesias, loss of sensory function or motor strength and control. Okay, so those are our treatment goals. So how do we do this? Okay, well, let's think about this again in terms of if this is a Taiyang urinary bladder jing-jin problem with posterior neck pain that is causing loss of range of motion due to pain in either flexion and or extension. Some of the things that can be helpful for this are local acupuncture and electroacupuncture, cupping and gua sha, and also joint mobilizations if the problem is in extension, manually mobilizing the joints, which has to be done with a certain degree of care in the cervical spine, but it can be very, very effective and very helpful. But we've got some contraindications here. Really strong manual therapy and really strong gua sha can actually make the problem worse by by further deranging joints. So we want to be gentle with our manual therapy in the cervical spine. And I just don't use gua sha and extension because to apply gua sha, we have to push into the spine, and I don't use deep tissue massage for the same reason. That further extends the spine and can exacerbate the problem. So we just keep it to acupuncture and cupping if they have a problem with extension. Okay. Suppose their problem was with side bending and rotation, and we've got more of a Shaoyang presentation with lateral neck pain. Again, we can use local acupuncture and electrical stimulation. Here we can do cupping and gua sha, but we still don't want to do really strong manual therapy. Okay. And how about the 5% scenario, or the much less common? It's really a stomach Yang Ming presentation with anterior neck pain. Again, flexion and extension may be symptomatic, but typically not really limited. Here we can do local acupuncture, but there's a lot of things we have to watch out for in the anterior cervical spine, and I want to get to that slide pretty soon here so you see what to avoid. My preferred technique actually is myofascial release, just gently releasing the sternocleidomastoid, the scalenes and other muscles in the anterior neck. And here we do not use electroacupuncture because it can alter blood flow to the brain, and it's contraindicated in the anterior neck. For the same reason, we don't want to use gua sha or cupping in the anterior neck triangle because it can diminish blood flow to the brain. Okay. Now, what about if they've got nerve and psychiatric symptoms? I mean, these are kind of two different things, but I'm putting them together in this table here. If we determine on our history and physical exam that we're dealing with spinal or central canal stenosis, and they've got trouble with extension, electroacupuncture is very helpful for nerve pain. And that's where I really reach for my eStim device, is where we've got nerve problems. Distant acupuncture can also help, but we need to do something locally with electrostimulation. And generally, I'm going to use cupping more than gua sha, as I've mentioned before, for extension problems. And we don't want to place the neck in an extended position. So don't elevate your face cradle high up. Either put them side lying or have the face cradle drop fairly low so the neck is more in flexion. The exact opposite is true with disc injuries, I should say. If we've determined they have a disc injury and we're treating their posterior neck, we want the face cradle to be elevated rather than dropped, okay, to put their neck back in extension. Okay. Now, if we've got radiating numbness, tingling, or pain going along a dermatome, then we want to apply that electroacupuncture traveling down the dermatome, as well as treating locally. Okay. And then psychosocial stress we can treat with distance and auricular acupuncture, gentle massage, etc. Strong local therapies are probably going to aggravate. Okay. So I'm actually going to skip over this section on distant acupuncture for neck pain because I think this is stuff that probably most of us are familiar with from either our master's level training or continuing education classes. You can look at the slides later if you're curious about how I apply. I use mostly Richard Tan's balance method, sometimes with some 8 extras or master DAOM point thrown in. But let's talk about local, okay? Now, we should, with anything of suboccipital, we need to be careful to angle towards the contralateral eye to avoid the brain stem, the epidural space, and the vertebrobasilar artery, just as we are taught in our master's level textbooks and teachers, right? Okay. The clean needle technique manual says no electrical stimulation, but there's no evidence basis for that at all, and people do it routinely. I've done it on literally thousands and thousands of patient visits without any problems, okay? So make your own choice about that, but I use it, okay? Using the extra point Bailao or the cervical Wato Jiaji, which are not described in CAM, but are in some other Chinese texts, we want to use those at the most likely affected segments. So you remember I talked earlier about the horizontal crease that signals the level of the cervical spine where there's trouble. Also, if they're limited in rotation, these are the levels of the cervical spine where rotation takes place. If it's a problem of flexion extension, we're more likely dealing with C4, C5, and C5 to C6. Or if it's just simply tender in that area, or we can palpate and find if it's tender in the spinous process, these are malaligned. Here we want to angle medially and caudally towards the tailbone and towards the midline of the spine to avoid the pleural cavity or the epidural space. Okay. So one of the points I really want to make is that there are no safe or dangerous acupuncture points. There are safe and dangerous angles. Okay, and again, our terminology, our translation trips us up if we think of points as two-dimensional structures, and we think, oh, this point is safe, that point is dangerous. No, I can make any acupuncture point safe or dangerous by where I angle. So I've already talked about most of this, but I want to highlight that gallbladder 21 accounts for approximately a third of pneumothorax injuries, and is from perpendicular insertion. I never, ever, ever insert needles perpendicular in the upper trapezius. Way too high risk, totally unnecessary. Anything that I might want to do with a vertical insertion of gallbladder 21, I can do through other means. Okay. Same thing with points on the locations on the anterior neck. I do not want to go angle a needle in an inferior direction because I can cause a pneumothorax. Okay. And I think the rest of this is self-explanatory. So some things you can do here to treat posterior neck pain that is more painful upon and may limit their flexion. If it's really an acute disc injury where you may actually feel palpable warmth and swelling and redness, or it's simply a very acute, they say it happened within the last couple of weeks and your physical exam and your history tell you to suspect disc, you can actually use superficial or 7-star needling. Actually can work fairly well on this with very minimal manipulation. And really strong manual therapy and stretching are contraindicated. They will irritate the disc further. Okay. But if it's chronic disc pain, or if it's myofascial pain, which may or may not limit their range of motion, here's a list of the muscles to really prioritize treatment. Okay, and we can use trigger point needling, which is a class in and of itself. We can use gua sha or cross fiber massage, meaning running our funicular to the fiber orientation. Myofascial release, which is gliding parallel to the fiber orientation. And there's a variety of manual therapies, as long as they're not really aggressive and really strong, that we can safely use. We can use mild cupping for disc pain and heat therapies, which on chronic, not on acute, but on chronic. Okay? So in this class, I'm just giving you these muscle charts. I'm only going to talk about one. I'm going to talk about the most significant here, but what I want to walk through is what's here. Okay, upper trapezius, shrug to protect the neck. That's really what the upper trapezius does. It's our cervical protection muscle. Okay, pulls the shoulder blades up to protect our cervical spine. It's a leg taiyang muscle. Structurally, functionally, it can also function as a shaoyang muscle. When it contracts unilaterally, it causes side bending and rotation. When it contracts bilaterally, it's functioning more as a taiyang muscle. But I call it taiyang because structurally it's the most superficial layer on the back of the neck. Okay. And so here I'm giving you PA, proximal attachments from the spinous processes to C1 to T12, and the distal attachments, where it attaches distally. I already sort of talked about the primary function. You can look at this in your own time for the details of what it does when it's contracted unilaterally or bilaterally. Interesting thing about the upper trapezius is it's one of the only muscles, the sternocleidomastoid being the other one, which is actually supplied for its motor function by a cranial nerve, not a spinal nerve. Here on the right-hand side is the referred pain pattern. So the referred pain pattern looks much more like shaoyang. So this muscle really is both shaoyang and taiyang. You can ignore the X's on these trigger point charts. These are from the myofascial trigger point manual of Travell and Simmons. The latest edition, they took out the X's because they have not stood up to the test of time. What's more important is palpatory skills to locate tender, taut, fibrous bands with a tender nodule in them that produce referred pain upon compression. And you might find them at any of these common locations, triple warmer 15, gallbladder 21, SI 12. But I encourage you to explore with your fingertips. And it's very common, of course, most of our patients who palpate around their upper trapezius, you'll find some taut, tender bands, and the patient will say, oh yeah, that hurts. There's a knot right there that I really feel, that sometimes will produce this referred pain pattern. And that's a place we want to needle into or use our fingers or a gua sha tool to break it up. But again, when we're needling, never perpendicular, keep it at transverse angle. The upper trapezius is just under the surface of the skin. And with a short needle, you can safely needle under the surface of the skin, get into those myofascial trigger points in the upper trap, and do a lot of good. Okay. These other muscles, I'm not going to take the time to go through because I want to leave a little time for questions. But the information, the way I've laid out the information is the same. There's the levator scapula, the semispinalis and cervicis, and the multifidi. The multifidi are very important to treat because they are the primary stabilizers. They're really a Shaoyin muscle that stabilizes the cervical spine, and you can get to them by needling the Wato Jiaji or Bai Lao and angling in that medial and caudal direction towards the tailbone and towards the spine. Okay. Local treatment of posterior neck pain that limits extension. Here are the limiting factors. We already talked about them. Treatment, suction cupping. We can realign the spinous processes through soft joint mobilizations. Use the Wato Jiaji. We can actually needle into the facet joints, but strong gua sha is contraindicated. So needling the facet joints requires some exam techniques, which I teach in longer classes. And when I'm going here's a written description, but I'm going to skip over it to here. To even if you don't do the full physical exam, but you simply find a tender facet joint through palpation, by needling it at approximately a 4 o'clock or an 8 o'clock angle, if 6 o'clock is the spinous process at the back of the spine, gets you into the facet joint. And the bony structures here protect the vertebro-basilar artery, they protect the trachea, and they protect the spinal cord. So this is really quite safe. However, it produces a very strong achy sensation that you have to warn the patient about. I do this to patients routinely all the time. It's very helpful. 2 or 3 days down the road, they're going to say, wow, my neck feels so much better. But the first day or two, it can be really stiff and sore and achy. Okay. Now, the anterior neck pain, here are the muscles that are typically involved, the scalenes and the SCM. But we have to be really careful about in the anterior triangle that we don't hit critical structures. So let's go to this graphic here. You can look at the written details as well. The safe zone is behind the sternocleidomastoid and 3 sun or 3 finger widths superior to the clavicle. And again, this is not just simply where you insert the needle, it's also, I do not want my needle tip to wind up in the danger zone, outside of the safe zone, okay? So that's where we have to pay attention, not just to the starting point, but to the ending point of the needle, okay? So do not angle in an anterior direction, do not angle in an inferior direction, stay within the safe zone, both for your insertion and where you stimulate. But that being said, when you're in the safe zone, you can actually needle straight towards the spine to get the scalene muscles and to get small spinal intrinsic muscles, and that's actually quite safe and can be very therapeutic, okay? All right, so we are very close to the end of our time here. You can read these on your own, but these are some of the presentations that elevate the risk of pneumothorax injuries. I did not know this until reading the clean needle technique manual, that's corticosteroid use, for example, which is extremely common, but also lung disease, small, thin body type, etc. Okay, and here are the locations of the highest risk of pneumothorax, and you can see gallbladder 21, top of the list, bladder 13, stomach 12, Ren 22. Those are the big 4. Okay, but of course, you know, the Wato Jiaji at the level of bladder 13 or bladder 12, you know, the adjacent locations are also higher risk. These are just simply documented and reported. Okay. Vascular injury can also occur by needling in the neck triangle. And so one thing I want to say about avoiding vascular injuries, it's really important to palpate for the pulse of the carotid artery or the subclavian artery. You need to know where they are in your patient. You can look at an anatomy book, and that tells you where they are in most patients most of the time, but there's anatomic variation in the course, and what you really need to know is where is it in the patient I'm treating right now. So you have to palpate to find the artery, and when you're inserting, go real slow and take your fingers off the needle frequently and watch and feel for an arterial pulsation, like 60 beats per minute. Okay. Here are muscles in the front. We don't have time to go through these, but look at these referred pain patterns. We won't go through these in detail, but these are some very interesting referred pain patterns. The sternocleidomastoid, headaches all over the place, the inside of the ear, the tip of the chin, under the jaw, back of the head, top of the head. I skipped over scalenes, but look how it goes all the way down the arm into the shoulder blade. So just because I'm saying, you know, be careful with your needles doesn't mean don't treat these muscles. They're very important and very therapeutic to treat. Okay. As I mentioned before, when you're treating nerve root, you got to treat all the way along the nerve pathway and use mixed frequency milliamp settings on your electrostim device. For example, 2 that alternates between 3 seconds of 2 hertz and 100 hertz. Okay, and you know, the clips can be applied on both sides of the cervical spine to block pain signals coming up from the periphery. And if we're dealing with a longitudinal nerve root problem, it has to go all the way down the nerve pathway as well. Okay. So that's the last slide I want to talk about. We already talked about gua sha and suction cupping, what not to do. What to do is very easy. And thank you very much for your time. And we've got about 5 minutes for questions, but I can stick around for up to another 15 minutes or so if we didn't get to some questions, if that's okay with Jeffrey.
Absolutely. Thank you so much. That was such a great webinar. I just want to let you know, I don't know if you were manning the chat at all, but during the entire webinar, people are just raving about how great the information is. I also don't want to take up too much more time, so let's just get right into questions because we have a fair amount. So first question, do you have any insights on disc replacement surgery? The patient with right hand weakness, cold, left hand pain, age 44 male, one doctor recommended surgery, another told to wait, also got an epidural in the spine, neck diagnosed with cervical stenosis.
Right. Okay. Well, that sounds like a very complex case and a lot going on there. I wasn't clear if the patient has already had the disc replacement surgery or they're considering it. In general, I would say I do everything I can to keep my patients out of spine surgery. I've seen some absolutely catastrophic failures where the patient is far worse off after the spine surgery than they were before. I've also seen some success stories. So you got to pick your surgeon carefully. And I always tell patients, get at least 3 opinions unless it's super, super urgent. Okay. And let me keep treating you because I can really do a lot for you. But once the disc has been replaced, there's not much we can do about that level of the cervical spine. It's no longer anatomical tissue. So you just have to manage the symptoms and treat along the affected dermatomes of the arm. That's about as much as I can tell with the information that you've given me.
Absolutely. And then this was in reference, it was around slide 14 or 15, but the same person recommended or asked, do you recommend distal or local TX for the same? And I made note of where it was in the presentation because
okay.
I wasn't 100%
All right. Let me go back to see if I can find slide 14. Generally, I would say both. You don't need to choose between distal and local. You can always apply both. Okay. Let's see. I think it was in not in the history and physical exam section, but the diagnosis section. But that's the simple answer is we get so hung up on this question in our profession about distal or local. You can do both. You can always do both. But I'll tell you what I do is I usually start on the first visit with distal, particularly with neck pain, because neck actually responds very well to distal. And I see how they respond. And if they respond well, great, let's keep going. We'll use our whatever it is, Richard 10 or TCM or Luojan and ear points, whatever. But if they only get temporary relief or very mild relief, or they don't get any relief at all, or it just kind of keeps coming back to the same place, as soon as I see them start to plateau or be dissatisfied or not get enough results out of the distal information, I start adding in the local. I can keep doing the distal, but I also need to do something local. I'm quicker to go to local if I see a structural problem in discs, facet joints, etc., whereas muscles and emotions respond very well to distal. Okay.
All right. Next question. When you said neck pain with headaches is a serious symptom to refer out immediately, it was the red text on slides 6 and 8. It says, does not apply to any level of headache, or does that apply to any level of headache intensity, or are we just concerned with severe headaches or any specific type of headache?
That's a good question, and it's a much bigger question than I can answer in a short webinar like this. I will say, when in doubt, refer out. Okay, headaches are loaded with serious problems, and patients don't always know how serious they may be. So we can't simply rely on the severity, because a headache that is just progressive and growing slowly and getting slowly worse, even if it starts out mild, that may be a slowly expanding tumor or a bruise in the brain, a subdural hematoma. So rather than rely on symptoms, this is why we all need to up our game with our physical exam skills. And there's no substitute for being able to do a cranial nerve exam. It's something that with a little practice you can do in less than 5 minutes and rule out an enormous number of very serious pathologies. So anytime a patient comes in and they say, I have a headache, first of all, I ask them, have you reported this to your family physician and or seen a neurologist? If yes, what's their impression? If no, or if I have any doubt about the accuracy of the physician's impression, or they saw their doctor years ago or whatever, when in doubt, I'm always going to do a cranial nerve exam. And it's a critical skill that's whose value is underappreciated at the master's level, but we should learn how to do our cranial nerve exam, be fast, proficient, accurate with it.
Perfect. Next question. You mentioned heat in different situations. Most practitioners in other modalities recommend ice to be applied. What are your thoughts on cold applications?
Cold is useful for short-term control of pain, and I would much rather have somebody use cold than take an NSAID or an opioid to control pain. But we can do a great job controlling pain, so I never recommend cold. Now, I also don't get into a battle with the patient or with some other provider about whether or not to apply cold. It's rather unprofessional for me to start, critiquing physical therapists for recommending cold, just like we don't like it when they critique the patient for going to acupuncture, right? So I'm like, I just ask them, do you feel like the cold is critical to your self-care and is it really helping you? If you're needing to apply a cold pack constantly, it's probably not really doing anything for you. Would you consider discussing with your physical therapist, giving the cold a break and see if heat works better or simply no temperature works better? Okay, so that's kind of how I handle that scenario. But I never use cold myself.
All right. Well, we still have a fair amount of questions here. So if you're still good with time, I'm going to keep going.
Sure.
All right. Perfect. Let's see. How do you reconcile electroacupuncture with the classics? Could you speak to how important electroacupuncture is in some of the conditions you described, such as peripheral neuropathy or radiculitis?
Yes, that's a great question. Thanks for asking that. I will say that electroacupuncture works much better on nerve problems than simply manual stimulation alone. Think of nerves as like a little electric wires, and they need to be used, or you have to use them or lose them, right? So applying electricity from outside is a way to jumpstart and getting a dysfunctional or injured nerve kind of reset to its normal functioning and juice it, give it what it needs to stay vital. And personally, I don't have any problem with doing things that are not described in the classics. There's no contradiction between the classics and using electroacupuncture. Any of you who've been to China know that electroacupuncture is extremely widely used in China because the Chinese don't have a problem with adding on modern modalities to their ancient classics. That's really an American problem or a Western problem where we get into these false dualisms that come out of Neoplatonic, good versus evil, thinking. But I will say that electrostimulation in medicine has very ancient roots, actually going all the way back to ancient Egypt, and first described in classical Greek and Roman medical texts. What am I talking about? Putting an injured limb in a basin of water with a torpedo fish or an electric eel that emits electric discharges was noted that it made wounds heal faster and pain went down. So it is natural. It is ancient natural medicine. So, and that's what I say to patients who are like, I don't know about this modern electrical stem cell. Like, well, it goes back a couple thousand years and it's used in China. Are you comfortable with it now?
All right. I would say so. Also, it feels really good. Let's see. Next question. How would you needle for scapular winging due to long thoracic nerve palsy and serratus and not firing? Huato Jiaji of C4, would you actually connect to serratus anterior?
You could, but that's kind of outside the scope of and that's really a long thoracic nerve is a shoulder girdle injury, and that's a difficult condition to treat. When small peripheral nerves are damaged, it does help to needle the Huato Jiaji at the affected level or the urinary inner bladder line, and then needle locally into the area supplied by that nerve using electrostim. Now, I don't like needling the serratus anterior. It's way too close to the rib cage for comfort for me. So I might use a surface electrode instead. But there are ways you can do it, but it's just outside of what I can teach in a class like this.
Absolutely. Let's see. What are your thoughts on collaborating with a manual lymphatic therapist, chiropractor, and or osteopath to treat neck pathologies?
Manual lymphatic, no problem. Osteopath, no problem. Chiropractor depends on what they're doing. The forceful crack and pop style of chiropractic, I think, is potentially quite problematic, and I have seen some pretty catastrophic injuries come out of that style of chiropractic. So I always, if the patient is asking me about chiropractic, I say there's nothing that they can do that basically, I don't think there's anything chiropractors can do with the neck that we can't do with a little bit of training. I just needle into the cervical facet joints. It has a much longer lasting effect than trying to crack and pop them. And all those patients that sign up for those plans where they're seeing a chiropractor 3 times a week for 6 months and they give their credit card to the chiropractor, That's not medicine to me. That's something else. And I apologize if any of you are chiropractors out there that do that, but quite frankly, if I can't get a patient, significantly better in 6 to 8 visits, I'm going to refer them out anyway. But there are chiropractors who do, gentle soft tissue mobilization and other techniques and stuff that, fine, no problem. I just don't like the forceful crack and pop. There's too much risk of injury to the spinal cord and destabilizing the cervical spine through repetitive stretching of the ligaments and joints. Usually the cervical spine needs the opposite. It needs to be restabilized. I'm going to go on a little bit here because it's a very good question. The bones and joints, the joints need to be restabilized so that the muscles can relax. So patients think their neck is tight, and that's because the muscles are compensating for underlying instability of the joints. And so they stretch their necks and they massage their necks, and things get worse rather than better. If you stabilize the underlying joints, then the muscles can relax, and then they will respond to therapy, and they don't need to be stretched. And they don't need to be popped either. Okay. So.
Are you coming to Boston anytime soon? Because I feel like I need some of your help. Let's get a real question in. But
right.
Next question is, do you have any additional recommendations for treating bone spurs in the cervical spine leading to spinal stenosis at around C6 or C7?
Yeah, good question. So my question, I'm going to fire a question back, which is the bone spur, what's the evidence that the bone spur itself is the source of the problem? If a bone spur is actually cutting into nerve tissue, yes, it's a problem. And that's a tough one for us to do anything about, unfortunately. They actually might be a candidate for surgery if it's a large bone spur that's damaging nerve tissue, because our methods for reducing bone spurs are going to work very, very slowly, if at all, over months and years. And a nerve that's being damaged by a bone spur, they may have only 6 to 8 weeks before they lose function permanently. But if it's a bone spur that's not cutting into nerve tissue, it's basically what we call kind of an anomalous finding, or what's the term? An artifact. That's the term radiologists use. Something that shows up on an imaging study that is of no clinical significance. And you take an MRI or an X-ray of any patient starting in their 40s typically, they're going to show some bone spurring in their cervical spine. Earlier, if they had bad whiplashes or neck injuries and stuff, and they may be of no significance whatsoever. And that's an important conversation to have with a patient, because in the modern era, I learned this the hard way from, I think she was the very third patient I ever treated in my practice for neck pain, was getting better. She went to a doctor, or she actually was referred by a doctor, but she was getting better. And then she went back to the doctor who read the X-ray to her, and the doctor who, was supportive of acupuncture but didn't have perhaps the greatest communication skills, said to the patient, your X-ray shows you have some bone spurring arthritis and there's no cure for that. And then she got worse and dropped out of treatment. Okay. So if I had the knowledge I had today, I would have said, well, wait a minute. Whoa, you're getting better. That's what's important. That's what's important, is you're getting better, right? If you didn't have the X-ray, the MRI, if you were a patient 100 years ago, all you would care about is you're getting better. Okay. So let's focus on your symptoms rather than what shows up in the MRI. There's a big disconnect, particularly in the spine. It's only about a 50% correlation at most between symptoms and imaging findings. So somebody asked, I saw this in the chat window, how do you stabilize the joints? That's what I was talking about, needling into the facet joints. Needling into a joint causes the ligaments in the capsule to tighten up, which is a good thing. We want that tight. We want the muscles to be loose and the ligaments to be tight. And that process, that happens immediately, which is really kind of remarkable. And I don't have a good explanation for why, but I just observed it over and over again. And then by tightening it up, by needling into it, over the next 6 months, that ligament will continue to bulk up and hypertrophy and get stronger and stronger. And then you'll be restabilizing your spine.
Are you still okay with a couple more questions?
Yeah, I can take a couple more.
All right, next question. There have been some really good ones. I have a patient with cervical stenosis, some minor bulging, and continued numbness on the anterior pointer finger. I've been treating with Huato-Jiaji. Do I need to be?
Yeah, that's a good use of Huato-Jiaji. That's what I would be doing. Yep.
All right, patient with chronic neck pain and history of cervical laminectomy several years back. He has a big longitudinal scar on the neck along the dew channel. Would you needle this, and how?
Yeah, you can surround the scar tissue, but the scar is a bit like the bone spur. is the scar actually causing problems, or is it just is it just, something left over for the surgery and the problem is deeper in there? Post-surgical is very difficult to do anything about. And that's, again, why I really do everything I can to keep my patients out of the operating room, particularly with spine. Now, there's other scenarios like, knee and shoulder where surgeries can do really great things that we can't do with needles. But spine, I've seen so many failures. And once the spine surgery's gone bad, basically all you can do is manage symptoms and refer them back to spine surgeons for consultation to see if they need a revision surgery. So, you can use Wato-Jaji, you can use electroacupuncture, you can use Distin, but you can't really do anything with the facet joint that's been, removed surgically, or a disc that's been removed surgically.
All right. What are your thoughts about spinal cord injury that causes loss of motor and sensory function on the lower limbs from the knee down, the patient slowly gaining sensory function?
Yeah, that's another tough one. I mean, these are good. These are the tough cases, right? You can do, the most we can do for the spinal cord is Wato-Jaji with electroacupuncture. There are some Chinese herb formulas that may be helpful depending on the pattern, but that's its own diagnostic world. When in doubt, I use the Evergreen Flex NP formula for neuropathic pain, but I don't think it's going to restore motor function. It just may help with numbness and tingling pain. But,
all right. How about let's do one more question?
Sure.
All right. Can we treat the nodules directly around lung 3 to lung 4 and Li8 to Li10 area with eStim?
Lung 3 to lung 4.
Or LU4?
Oh, Li.
It says LU.
LU, yeah. Well, that'd be the upper arm. Yeah, I'm not really sure what's being referred to there.
So maybe it was supposed to be Li.
And then what was the
Li3? It says LU3 to LU4 and Li8 to Li10.
Li8 to Li. So yeah, you're talking arm there. Yeah, I'm not really sure what you mean by nodules either. So I'm sorry.
Okay.
I mean, no, yeah, but I would say that there's no contraindication to use electroacupuncture for on arm locations. Yeah.
All right. You know what? I think let's just end it here. So okay. We cannot thank you enough. This was such a fantastic webinar. I know everybody enjoyed all of the content, all of the questions. Please let them know where they can find more information from you and if you have anything, upcoming.
Sure. Yes, absolutely. Yeah. So my last slide here has my contact information, my website, and I am teaching a live webinar on the 5th and 6th of February, the weekend of 5th and 6th of February for CUs and live CUs and PDAs. That's really on not just the neck, but also the thoracic spine and also the head and TM joint. But we're going to go into much more depth, obviously in 16 hours. And so that's the next class I have coming up. And there's some resources there available for distance learning as well. So, and that's the first of a whole series on the spine extremities that I'll be teaching once a month from now through June. So be happy to see any of you there, and that's how you can get in touch with me.
Well, I would be shocked if you don't. And I want to thank all of you so much for joining us tonight for this webinar. It has been my pleasure to be here. And again, it's my pleasure to host Anthony, and we will see you all next time. Have a wonderful evening.
Thank you so much, Jeffrey and Los OMS, and thank you everyone for attending, and hope to see you in the future.
All right, thank you. Take care, everyone.